lot of lectures starting at 8 o'clock, and I'm just going to say right now, let's just plan on 8:15, because I am not I'll be lucky if I get here at 8:15. So, I'm just not an early bird person. I'm so bad at that. So. Do what? So hard. I can stay up till 3 o'clock in the morning, but. Okay, so today we're going to talk about the various infections of the skin, and I've got them on separate PowerPoint, so I'll have to kind of change PowerPoints along the way. We're going to talk about that, and then if we have time, we'll talk about the exanthems. If not, we'll shove that into tomorrow. I think we'll have time, though. And I kind of got off on a tangent yesterday about the procedures, and I failed to tell you we will actually do that. We're just going to move that into capstone instead of during this section. I felt that that would be an appropriate move. So, excuse me, my allergies, when it's kind of rainy like this, my allergies are horrible, so forgive me for having to clear my throat a lot. Okay, so the first infections of the skin we're going to talk about are the fungal things. One of the gals who's talking today and tomorrow is going to talk about true fungal infections. So I'm going to talk about the Candidiasis, which is a fungus, but it's more in the yeast category, okay? So out of the yeast, C. albicans, Candida albicans is the main player with this. Again, Candida, I'm just going to call it Candida. Candida is a natural part of the flora in most people, or not in most, but it can be normal in the mouth, the GI tract, for sure, the vagina. And it likes to grow. In fungus, yeast loves warm, moist environment. So anything where there's that condition, it's going to encourage that growth. When you've got skin folds, when you've got tight clothing that encourages that atmosphere. Some other things, obviously, diabetes, obesity, when you have more, overlap of skin and things like that. And then anything that can kind of disrupt that normal flora on the skin or in these areas with the use of oral antibiotics or steroids can encourage the overgrowth of the yeast. And it's also in immunocompromised people that are immunocompromised, your HIV, people that are on, getting cancer treatments, things like that, they are at much greater risk of getting these infections. You can do a KOH prep. That's where you scrape the skin with a blade. I usually will use a 10 or 15 blade. That's more of a curve. You don't want to use the pointy blade. But a curved blade, you just scrape that gently. I usually will do kind of at the border edge of it. Get some of those skin cells, wipe that on the slide, then you'll put a drop or two of potassium hydroxide, or KOH, and sometimes you need to let it sit there for a bit, or put it over some heat, and with that you will see the budding yeast and the pseudohyphae, and that's what that will look like. So I would be familiar with what this looks like under the microscope, and it's the skin scraping and the KOH that you use. Bless you. Oh, sorry, I didn't want to close the door. Okay, so mucocutaneous. Mucous membranes and the skin. The yeast can invade both of these different types of cell types. When it involves the mouth, oral candidiasis, that's also called pseudomembranous candidiasis or thrush. You know, you typically think of little kiddos, little babies, newborns that get thrush. Little adults can get that as well. That's the most common form of oral yeast infections or oral candidiasis. Things that we talked about before will increase your risk of this. Systemic or topical steroids, topical meaning inhaled steroids. My husband has had this. He has asthma, and when he improperly uses his steroid inhaler, he gets it too much on his tongue, and he will get an overgrowth of yeast. So I thought I just closed that. Making things up. Losing my mind. It's another day in my world. Okay, so predisposing factors. With this, people can be asymptomatic or very commonly will have kind of a burning discomfort, especially if they aggravate it with spicy or acidic foods. They may notice that their taste buds just aren't working as well. So with that, what you're going to see are these white patches, and when you, typically on the tongue, buccal mucosa, hard and soft palate, and it can even go down further that you may not be able to visibly see without some kind of a scope. But what happens is it's a pseudomembranous, so you can wipe away that membrane, the white patch, and underneath it you have more of a red, shiny surface, mucosal surface. There's a variant called atrophic candidiasis in the mouth that you generally see with when you have a tongue that doesn't have the tiny little bumps, the papillae. It's depapillated and it looks very atrophic and shiny. Okay, that's another variant. And you will oftentimes see that with denture stomatitis, this atrophic candidiasis, when they have ill-fitting dentures and they will get an overgrowth of yeast under there, and it can be, you know, kind of problematic for them. So chronic redness, swelling of the gums there underneath the dentures. And again, I'm not going to go into huge details of treatment because I know Dr. Latassi will be doing that. Oral candidiasis for mild to moderate, you've got lozenges or liquids that you can kind of swish and spit or swish and swallow depending upon, you know, how involved it is. For more severe infections, it's traveling, you know, down into the esophagus, or if you have an immunocompromise where a topical just is not going to cut it, you're going to use an oral systemic medication. Little babies sometimes will even use the purple gentian violet, and we use that on the skin a lot too, especially in body creases for not just yeast, but we're going to talk here a little bit about intertrigo. It just really helps to dry that out. It has antibacterial, antifungal properties. It stains purple for a couple of weeks, so I always will warn somebody and say, you're not getting like family pictures anytime soon, are you? And just let them know that it's gonna, you know, and sometimes it'll, like women that get, obese women that will get bad intertrigo or yeast infections of the leg creases will, you know, rub gentian violet all in there and it'll stain their underwear, but just warn them, and usually they're like, I don't care what it stains, just get rid of this rash and itch. So this is what thrush oral candidiasis will look like. And again, when you scrape that white pseudomembrane away, it will be more red and shiny under there. This is more what you see with the atrophic candidiasis. See how you don't see the little, It's papillated, and it's just shiny red. And it's probably usually going to be more red than that. That's just more of a pink. It doesn't look grossly abnormal as far as the color goes, but probably just the picture didn't give it justice. Other forms of mucocutaneous candidiasis is angular cheilitis, okay? It's got a couple other names, perleche. I hadn't even heard of that term until the last several years. That's when people will get these fissures in the corner of their mouths. Typically, they'll lick that area, or they have ill-fitting dentures, or at night they tend to slobber and or drool, and they get a lot of moisture accumulation in the corners of their mouths. They get a tear or fissure in there, and then they get an overgrowth of yeast. And you'll see just a white debris accumulation. It will look red and inflamed. Sometimes you can get that with riboflavin deficiency as well. So if it's a very chronic something, I mean, this tends to be chronic anyway, but if it's more severe and just not seeming to respond, I would for sure check for that deficiency and treat it if it's there. Typically with this, we treat both a combination with a mild topical steroid as well as an antifungal, anti-yeast medicine. You need to kind of calm that inflammation down with that steroid, but the steroid alone may make it worse after a period of time anyway. I like to always recommend that people very frequently, especially at bedtime, apply Aquaphor or CeraVe ointment or something greasy all over the lips, but especially pretty heavy in the corners of the mouth. And then again, treat any vitamin deficiencies if you happen to see that. And that's what that will look. Sometimes it'll even, as people get older, they'll get the big marionette lines, and it will just go, quite a bit down onto the chin area. And you're going to see that a lot. I would treat kiddos with Accutane, and even though they're dry as could be from their Accutane, they're just constantly licking those lips, and I see that a lot in the teenagers too. Another area, and again, I'm not going to harp on this a lot because I know you just got through with this, but you can also have overgrowth of yeast in the vaginal area. You know what the risk factors are. Oral antibiotics for sure just disrupts that normal flora, allowing that yeast to overgrow. You have that thick cottage cheese-like vaginal discharge, lots of itching, lots of burning. You can treat that with topical medications, either over-the-counter or prescription, and then there are some oral anti-yeast medications too, such as the diflucan. Diflucan has changed the world with vaginal yeast infections, I think, for women, or fluconazole. And there is a spec exam, that thick white, you just can't mistake that. Balanitis is kind of the man's version. This is when you get overgrowth on the penis. And diabetics, if a person is uncircumcised, naturally you just have that foreskin that allows, again, moisture to collect there and allow just a perfect environment for that yeast to overgrow. Or sometimes if a woman has very frequent vaginal yeast infections, she can spread that to her partner. Same symptoms, itching, burning. And with this, you're going to just have, again, red with white patches on top. And the treatment is pretty much going to be the same. So again, that's just a smaller version of what you've seen. On the skin, cutaneous overgrowth of yeast, or Monnelia or Moneliasis. That's a mouthful, isn't it? That's another term that you may hear for the very same condition. Again, think of skin folds, your intertriginous zones where it stays warm and moist, especially in the summer months. You know the predisposing conditions. And again, with this, you're going to get usually pretty bright red plaques. And the key here are satellite lesions, okay? And those can be little red papules. They can be almost blistery sometimes, but you're going to look for those satellite lesions, all right? That's definitive of true yeast, okay? So there you can see the main plaque of involvement, but in both of those you see those little distant lesions. Does that make sense? Mm-hmm. I think before I got into dermatology and I was just working family medicine, urgent care, I called a lot of stuff yeast or candidiasis that wasn't true candidiasis. You're looking for those satellite lesions, so key word right there. Don't worry about that chronic candidiasis. There's a subset of people, very rare. It has to do more with genetic predisposition. You can get systemic candidiasis in the severely immunocompromised. Again, your cancer patients, your HIV, or not HIV, but AIDS, the more advanced. Post-transplant, they're on all kinds of immunosuppressants, things like that. And that's just where you're going to get a disseminated widespread rash. And amphotericin B is what the treatment is going to be with that. High mortality rate with that. All right, so intertrigo is what I talked about. Intertrigo is, even though it's not a true yeast, yeast infection, I like to put it in here just because I think people kind of get the two mixed up. With this, you're not going to see the satellite lesions, but you're going to see, again, in those intertriginous areas where you get skin against skin and friction, you get more inflammation, just true inflammation, and maybe a little bit of an overgrowth of yeast, but we don't call it a true yeast infection. So again, the burning, itching, redness, macerated, it just stays kind of moist. But it can get secondarily infected with either bacteria or with yeast. I always like to assume there may be a little bit of yeast in there. So again, kind of like with the angles of the mouth, the angular cheilitis, you do a little bit of a mixture. You do low potency steroid in combination with the antifungal, anti-yeast medicine, or I will at least start it out with the anti-inflammatory, topical anti-inflammatory for a few days, and then maybe take that away. Trying to keep those areas as dry as possible is key, and that can be real challenging in an obese, I'm just using woman because I see that more in women, especially in the dead of summer. There are some products that sometimes you'll say use a hair dryer, to the body creases after you get out of the shower so it's good and dry, and then apply, there's Drysol, which is an antiperspirant. You wouldn't want to use that when they have a true rash, because that's going to burn like crazy, but to more preventative, once you get the rash cleared up, there's an over-the-counter extra absorbent powder called Zeazorb, and they have Zeazorb AF antifungal that I recommend a lot. This is oftentimes when I will, widespread apply that gentian violet. And sometimes people will come in and, every couple of weeks during the summer months just to get that gentian violet applied. Okay, another kind of variant, or it's not a variant of yeast, but Tinea versicolor or Pityriasis versicolor. Both the same, different name, same condition. There is a group of yeast called Malassezia or Pityriasis that is normal on every single person's skin, okay? Every single one of us have this. Some of us are really prone to overgrowing this, especially when we're hot and sweaty, all right? I see this every summer. Athletes, construction workers, people who work in factories where you are just hot and sweaty all the time. And sometimes this can be a year-long thing, not just summertime. I had a tennis pro who just struggled with this year-long just because she was always hot and sweaty. And this is not going to necessarily be in the creases, although you can sometimes see it in some of the creases, but you tend to see it more on the trunk and the back. And you get these small round patches or plaques of either lighter or darker pigmented skin, hypo or hyperpigmented skin with a fine scale. Okay, sometimes with the naked eye you can't really appreciate the scale, but when you get a tongue blade or a blade, surgical blade, and scrape that on that plaque, then you'll really notice that scale coming up. And whether it goes lighter or darker kind of depends upon the person's baseline pigment. In my pigment tone, I will probably have darker patches, okay? In your pigment tone, you're probably going to have lighter colored patches, again, just because of our baseline pigment. Again, the most common place I see this is on the chest, back, but you can see it in the intertriginous areas as well. Sometimes you'll only see it there. People don't usually complain about this. They may have a little bit of a mild itch, but it's mainly when they become hot and sweaty or they're in a warm shower. That's when it tends to become more symptomatic. Typically, you're just going to know this by seeing it, but some other things you can do a KOH and look at that under the microscope, a skin scraping and look at it under the microscope. You can also look at it with a woods lamp or the black light, and it will give kind of a yellowish fluorescence. You'll have to turn the light out, and then you'll just kind of shine the black lamp or the woods lamp on the affected area, and you'll see it turn kind of yellowish. When you look at this under the microscope, it's going to look almost like a spaghetti and meatballs is what that term is. You're going to know that term because you're going to hear that. I know, isn't that yummy? The hyphae and the yeast cells is what that pertains to, and I'll show you that's the spaghetti and meatballs. Okay, so I'll come back to this. So this is what that looks like. Here on the screen left is where you get the hyperpigmented patches. On screen right, they have hypopigmented patches. And again, just looking at that, you really can't, especially on screen right, you can't really appreciate much scale there. But again, if you get up close and scrape it, you should notice scale. And then that is the black light or woods lamp. Okay, treatment again is going to be with your anti-yeast medications. Topically, I oftentimes will use shampoos because this tends to be pretty widespread, and a person can easily, what I will oftentimes do is say, okay, get some Selsun Blue shampoo and apply this to your skin almost like a lotion before you jump in the shower. Let it sit on your skin wherever you tend to get this. let it sit there for, 10 minutes or so while you brush your teeth and shave, and then jump in the shower and you can wash it off then. There are other topical anti-yeast medications that you can apply and leave on. They have creams, they have solutions, they have foams now. Now, if it's really widespread, you can use oral medications. Typically, the ketoconazole, that now has a black box warning, so you try to stay away from oral ketoconazole as best you can. Stay away from the oral terbinafine. Lamisil, that's better for true fungus rather than these yeast. Okay, they're in the same family, but we have medications that tend to work better for true fungus and better for yeast. And always warn them that pigment change, that's not going to clear immediately. So what I usually say is what you're looking for when the rash is clearing is that the scale and the symptoms go away. That pigment will eventually go back to normal, but it's going to take several weeks, maybe even months. Recurrence is incredibly common. Oftentimes too, what I will say is if you know you're going to start coming down with this, you're an athlete and you're starting 2-a-days and every summer you get this, then start treating yourself before it happens. Apply that shampoo, before you get in the shower, like 3 times a week, and see if we can keep the amount of that yeast, Malassezia, at a normal level on your skin. That make sense? Mm-hmm. And we looked at all this already. Here in a little bit, am going to talk about folliculitis, and Jennifer Devon, either today or tomorrow this afternoon, or tomorrow afternoon, is also going to talk about folliculitis. Folliculitis is inflammation / infection of the hair follicle, down at the base of the hair follicle. By far the most common organism that causes that is bacteria. Okay, but there are a couple other variants that can cause inflammation, infection of those hair follicles, and one of them being this Malassezia or Pityrosporum. Okay, again, you're going to see this more so in people that exercise a lot and just are hot. Again, you're going to see the little discrete folliculocentric, that means having to do with those hair follicles, folliculocentric inflammation and or tiny little pustules. And what's kind of different about this versus regular bacterial folliculitis is this tends to be a little bit more itchy. Okay, that's kind of unusual for your run-of-the-mill bacterial folliculitis to be itchy. So that's a kind of a good question to ask. Sometimes, or you can, again, scrape some of those pustules or papules and look for the Pityrosporum or Malassezia underneath the microscope, looking for the spaghetti and meatballs. Treatment is going to be the very same as for the tinea versicolor. And again, reoccurrence is very common, so you might think about giving them some prophylactic treatment options. Okay. Questions thus far? And this is pretty common. I have mainly seen this probably upper chest, upper back, sometimes even creeping up onto the neck and the face a little bit too. But again, how do you differentiate this from bacterial? I was just going to say it. I think common things being common, most of us are probably, before we jump into a biopsy or culture or whatever, I'm just going to say, okay, folliculitis, 90% of the time or more it's bacteria, so I'm going to treat you for bacteria, with topical, we'll talk about that. And if you just do not respond at all, then I might go a different route and try an anti-yeast. Now, again, if you say, okay, how much do you exercise? You know, do you work out every day and it's middle of summer? And it tends to have just a little bit, they tend to be a little bit more discreet. I don't know, it's kind of hard to describe, but, and then you can scrape it. If you have any kind of a question, you can scrape it and send that off. I would look at it myself, but in a family medicine clinic, you'll probably scrape it and send it off for KOH. Yeah.
Does bacteria wise tend to be as widespread as this, or is that mostly just yeast?
It can be, yeah. It can be very difficult. Again, I think asking about the itching, getting a little bit of that history, is this person just a major, you know, workout person and it just kind of fits that? But by and large, I am going to probably treat it for bacteria first, and if it just doesn't even respond, given an appropriate treatment for bacteria, then I'm going to switch gears. Okay, that is the yeast. Let me switch gears if